Welcome to the deep dive.
Yeah.
Now, forget the lecture halls, forget wading through dense legal textbooks. Today, we are cutting straight to the absolute core of one of those highly tested, high-stakes topics in all of medical practice and law, adult consent. This is, well, it's the difference between safe, lawful, ethical care and, frankly, a future legal nightmare.
It really is. This is the foundation of modern healthcare. I mean, when we talk about consent, it's not just about legality. We're talking about patient autonomy. Our sources today, they synthesize core GMC guidance, the game-changing Montgomery ruling, and the non-negotiable requirements of the Mental Capacity Act 2005. They all show that getting this right protects absolutely everyone involved.
And that's really the mission for you, the learner. We're distilling these, complex legal and ethical duties into a really robust, practical framework. The highest scoring professionals, they get this. They understand that consent is not some legal hurdle to clear. It's a necessary shared process. It's explicitly a process, not merely a signature.
Right. And we're here to give you that shortcut, that mindset that achieves real shared decision-making every single time.
Okay, let's unpack this.
So when we're talking about adult consent, everything, and I mean everything, it all flows from three basic non-negotiable requirements. The three pillars. First, the patient has to have capacity to make the decision.
Okay, capacity first.
Second, the consent must be voluntary, so free from coercion or any, undue influence. And third, the patient must be informed. They have to have enough information to make a genuine choice.
And it's that third pillar, isn't it? The informed part. That's where the most profound shift in the law happened nearly a decade ago. We used to operate under a very paternalistic system, the whole doctor knows best approach.
Completely.
So tell us about that seismic shift, that Montgomery v. Lanarkshire Health Board ruling in 2015. What was the old standard, and I guess why is it now obsolete?
The old standard, well, it was what we call the Bolam test, and it applied to information disclosure. It basically asked, would a responsible body of medical practitioners have disclosed this? So it put the power and the definition of what was necessary information firmly in the hands of doctors. And that is gone. It was just deemed too paternalistic. It prioritized the doctor's view over the patient's right to self-determination.
So the law now is all about the patient's perspective being paramount. But how exactly does Montgomery define the information we have to provide? What's the new legal obligation?
It's very clear. It requires the doctor to disclose two things. First, all material risks, and second, all reasonable alternatives. But the crucial part is how it defines a material risk.
Right.
A risk is material if a reasonable person in this patient's position would be likely to regard it as significant.
That phrase, in this patient's position, that seems to be the entire ballgame. It's what separates, generic box ticking from actual tailored care. Can you give us a concrete example? How does that tailoring look in practice?
Absolutely. So imagine you're consenting a patient for, let's say, routine knee surgery. The generic risk of a small chance of nerve damage might be, say, 1%. For most people, that's just a statistic. But what if that patient tells you they are a professional musician, and they rely entirely on the dexterity of their foot to operate a pedal for their instrument? Suddenly, that 1% risk of permanent nerve damage is absolutely material to them.
Of course.
You have to highlight it. You have to discuss its specific implications for their life, for their livelihood. Even if this statistic is low, it has to be individualized.
That makes perfect sense. So it's about listening to the patient's actual values and priorities, not just reading off a standardized risk sheet from the hospital.
Precisely. And what's more, Montgomery demands you cover all reasonable treatment alternatives. This is such a common trap. If you don't offer the alternatives, you can't argue the consent was informed.
Yeah.
And you have to remember the most basic alternative of all.
Doing nothing.
The option of doing nothing, opting for no treatment or watchful waiting. Failing to discuss no treatment is a breach. Plain and simple.
So the core lesson here is that our legal duty shifted from basically avoiding malpractice by just doing what other doctors do, to actively ensuring patient autonomy by tailoring disclosure to that individual. That's a massive philosophical and practical leap. Here's where it gets really interesting. Let's move from the legal theory to the practical side of things. Let's establish those clear, stepwise actions you need in a high-quality consent discussion, the process that ensures you meet all the standards at once. Our sources break this down into a first, next, last framework.
And this framework is so vital because consent is a longitudinal process. It's not a single event, and this helps you structure that conversation logically. So, your first steps,
Yep.
they all revolve around setting the stage for shared decision-making. You've got to outline all the options available,
Including the alternative.
including the alternatives, and establish the goals of treatment from the patient's perspective. What does success actually look like for them?
And once we've opened up that discussion, the next crucial step has to be satisfying that Montgomery requirement, doesn't it?
Exactly. Step 2 is to explain the material risks and reasonable alternatives that we just talked about, but you can't just list them. You have to individualize them based on what the patient has told you are their goals and priorities.
Now, step 3. This is arguably the most frequently missed high-scoring action in any assessment scenario, and that's supporting understanding. I mean, it's so easy to assume the patient just got it after a 5-minute consultation.
That assumption is dangerous. The high-scoring action here is the teach-back method. Don't just ask, do you understand? That just invites a polite social yes.
Right.
Instead, you have to ask something like, could you tell me in your own words what we discussed about your recovery time? Or, what are the 3 most important things you're worried about, and how does this treatment address them? This confirms true comprehension. It proves the patient can actually use the information.
That level of verification seems absolutely critical, especially if you're talking about complex or high-risk procedures.
It is. And if there is a language barrier, this is a crucial red flag. Never rely on family members to translate. You must arrange for an independent, certified interpreter. Using a family member, it can compromise voluntariness, accuracy, it can invalidate the consent. It's an immediate safety breach.
What about step 4? That one's conditional, right?
Yes, exactly. Step 4 is assess capacity only when indicated. You don't do it for every decision. You only pause the process and use that formal Mental Capacity Act test if there are reasons to doubt capacity. Things like delirium, fluctuating cognitive status, acute intoxication, or just wildly inconsistent decision-making.
And finally, the last step, step 5.
Step 5 is robust documentation. Record the entire discussion, the options, the risks tailored to the patient, the alternatives, the final decision. This creates that essential audit trail, that safety netting. If it's not documented, then legally the discussion didn't happen.
And to make those steps stick, there's a fantastic memory aid in the study guides. It's choice, CE, C for check capacity, H for help understanding, O for outline alternatives, I for individualized risks, C for confirmed decision, and E for enter notes. That really ties the whole conversation together beautifully.
It really does. But let's dedicate some time now to the next part, because this is where integrity and law can clash with emotion. We need to talk about avoiding the common traps, especially around capacity and refusal.
Ah, yes. When a patient is facing a life-saving treatment but refuses it, the instinct for many is to persuade them, or worse, to assume they lack capacity because their decision just seems irrational. That's a massive trap.
It is the single most dangerous trap. The core reasoning that will absolutely tank your score is equating an unwise decision with an incapable decision. They are not the same thing. The patient has the absolute right to make choices that seem illogical or unwise or even harmful to us as long as they have capacity.
So if we suspect a refusal is based on a lack of understanding, we have to use that formal 4-part test under the MCA. Let's break those 4 elements down.
This is fundamental. The patient must be able to, 1, understand the relevant information. So the diagnosis, prognosis, treatment options. 2, they have to retain the information long enough to use it. 3, they must be able to use and weigh the information as part of their decision-making process. This is the most complex part. Can they articulate why they prioritize quality of life over quantity, for instance? And 4, they must be able to communicate their decision, verbally, in writing, by any means.
Could you give me a scenario where a patient might fail only one of those parts, but still be deemed incapable for that specific decision?
A classic example involves the 3rd point, use and weigh. Imagine a patient with severe untreated depression. They might understand the mechanics of chemotherapy and the side effects, that's parts 1 and 2, but because their perception of the future is so overwhelmingly negative due to their illness, they can't adequately weigh the benefits of treatment against their current overwhelming despair. So they are incapable of using the information rationally in that moment. It's why capacity is always decision-specific and time-specific.
That distinction really clarifies why a formal assessment is needed, rather than just reacting to the refusal itself.
Yeah.
Okay, what about the other big trap, the one involving family members?
Yes, this is insidious and, well, unlawful. Never fall for the trap that says the family can override a capacitated patient's refusal. The reasoning is simple. The family has no legal right to make decisions for a capacitated adult. Even if the entire family is united and the patient is alone, the patient's autonomy prevails. The family's role is consultative, it is not authoritative.
So let's put it all together. The patient has confirmed capacity, you've used teachback to ensure they understand, and they still refuse a high-benefit, even life-saving treatment. What is the ultimate required action?
You must respect that refusal, without coercion. You document everything, confirm the patient understands the consequences of their refusal, and you offer thorough safety netting. You explain when and how they can seek help if their condition changes or if they change their mind. Anything else, any coercion or unauthorized treatment, is unlawful battery.
Right. We've established the robust conversation process and the legal checks. But why do our sources put such a high premium on documentation? We said it was the last step, but what specifically proves a good discussion actually took place?
It's the proof. It's the proof that the Montgomery standard was met. A signed form with a date is necessary, sure, but it's totally insufficient on its own. Good documentation has to reflect that shared decision-making process.
So what does that look like?
It means recording specifics. 1, the tailored risks discussed. For example, discussed 1% nerve damage risk, focusing on its impact on his job as a musician. 2, the reasonable alternatives you offered, including no treatment. 3, the patient's questions, their stated values, their priorities that guided their choice. And 4, confirmation of their understanding. Ideally, you'd note that teachback was performed successfully.
If we connect this to the bigger picture, this detailed level of record keeping is what aligns practice directly with the GMC's Good Medical Practice 2024, particularly Domain 2, which requires clear, accurate, timely records of all important decisions and the reasons for them. So it's not just about covering yourself. It's about providing continuity of care that respects the patient's journey.
Exactly right. Imagine a different doctor takes over care 6 months later. They need to know why the patient chose a particular path, what risks they accepted, what their primary concerns were. This ensures that any subsequent treatment remains respectful of that patient's initial autonomous decision.
That brings us to the end of a truly rigorous deep dive into adult consent. It's clear this is a subject of profound legal, ethical, and practical complexity. So what does this all mean? We've covered a massive amount of high-yield content. Let's summarize the 3 core takeaways that you need to apply instantly.
Okay, first, remember the Montgomery rule. Material risks and reasonable alternatives must be covered every single time, and critically, they must be tailored to what matters to the patient in their position.
Second, always support comprehension. Provide time, use accessible information, and deploy that teachback method to confirm the patient's true understanding. And never, ever substitute a certified interpreter with a family member.
And third, respect capacitated refusals without coercion. Unwise decisions do not equal incapable decisions. Check capacity only when red flags appear. Use the 4-part MCA test, and if they pass, their choice stands.
We focused so intensely today on adult consent and the absolute nature of adult autonomy when capacity is present. But the sources often reference related topics like consent in children, where we rely on concepts like Gillick and Fraser competence. So if a capacitated adult autonomy is absolute, this raises an important question for you to think about. How does the concept of competence in children legally challenge or redefine this principle of informed choice? And where does responsibility shift when the patient is capable of understanding but isn't yet fully independent?
That introduces the whole nuance of parental responsibility versus developing maturity. It's a fascinating area where the law recognizes more of a sliding scale rather than the absolute binary we see with adult capacity. That's a key distinction to ponder.
Use this robust framework on consent, from the initial options discussion through the teachback all the way to the final detailed documentation, and you will be positioned for success and excellence in your practice.